Hello, everybody, and welcome to our TIF Talk Tuesday. I'm Andrea Millers, the Senior Director of Marketing at Endogastric Solutions. And today I have Karen Girth here with me, a Market Development Manager as well. Say hi, Karen.
Hi, everyone.
And we do have a special guest today. We have Dr. Jorden Marble here. Thank you, Dr. Marble, for being with us today. And thank you. So just to give you, Dr. Marble received his medical degree from University of Arizona College of Medicine in Tucson and has been in practice for over 10 years. He is highly trained to do the TIF procedure for reflux at Mount Graham Regional Medical Center in Arizona, Safford, in Arizona. Is that correct?
That's correct.
Fantastic. Well, welcome and thank you for joining us tonight. I do want to remind everyone that's watching, if you have any questions at any time, please feel free to type it into the chat section and we will do our best to answer all of your questions. So today we usually start off by kind of answering the question, what is GERD? So can you please explain, Dr. Marble, what is GERD?
GERD is defined as gastroesophageal reflux disease. It is usually a conglomerate of symptoms caused by acid reflux that is exposed into the esophagus, basically, right where the connection from the stomach to the lower part of the esophagus. Generally, symptoms occur right in that area that patients can experience for months to years. Usually it's their lifetime. And it comes about because of basic changes within their body or body habitus, or sometimes a hiatal hernia can occur and decrease the efficacy of the acid staying down into the stomach and into the esophagus.
Yeah, can you talk a little bit about the different types of symptoms a patient would potentially feel if they were suffering from GERD?
Yeah, so generally most patients will experience they call it reflux or symptoms of heartburn. Typically happens right in the mid-epigastric area, right in the middle of the chest. So this also another symptom is chest pain. Frequently there'll be patients that go to the emergency department thinking they're having a heart attack, but the majority of the time they are just experiencing this reflux symptom. Other symptoms that can occur are maybe chronic cough, problem swallowing, maybe food getting stuck after swallowing and food getting stuck in the middle of their chest. Discomfort as well in the same area. Less frequently, people may experience symptoms of asthma or coughing or choking symptoms, especially in the evening or after eating late at night, going to bed. They can experience this while laying down as well.
Right, thank you. What do you normally recommend patients to do if they are suffering from acid reflux or chronic GERD, if you will?
Yes, so the initial evaluation should always talk to your primary care physician about these symptoms. They may prescribe you a medication. Usually they'll also educate you on things that you can do better, like change certain habits. So if you eat late at night, don't eat late at night, because if you eat late at night and you lay down, that's when your stomach is full and that's when acid can go up into your esophagus and be exposed there. But that's probably the first thing you should do is talk to your primary care physician.
Fantastic, thank you. What types of lifestyle modifications generally, would you recommend? I know you said, don't eat late at night. Are there different foods or food aversions or things that actually trigger acid reflux?
Yeah, so generally caffeine's a huge one. Lots of caffeine throughout the day can increase reflux symptoms, as well as chocolate. Avoid chocolate. So spicy food, tomato-based food as well, like spaghetti and lasagna, all the stuff that we love.
Yeah.
Should avoid that. Maybe either eat it earlier in the day or avoid them altogether.
Fantastic, thank you. And what options are available today? You did talk a little bit about medications. Can you talk a little bit about the different options for treating GERD today?
Yes, so besides the lifestyle changes, diet modification, next would be medication-based, so PPIs, proton pump inhibitors, like Protonix, which is pantoprazole or omeprazole. There's H2 blockers as well, such as ranitidine. And then from there, generally, we have to kind of define, all right, why are you having reflux? Because once medications either aren't useful enough, or if you don't want to take medications for the rest of your life with their bad side effects, then we discuss performing procedures, anti-reflux procedure surgery to fix the problem.
Sure. Can you talk a little bit about the diagnostic workup to determine A, if a patient truly does have GERD, and then B, are they even a candidate to potentially have a reflux procedure?
Yes. So one of the first diagnostic tools that we use is endoscopy, or an EGD, usually what we call it, where a camera will go down into the esophagus and into the stomach and evaluate the integrity of the hiatus, meaning is there a hiatal hernia that's present? Is the so-called valve that we say at the G junction, is it intact? Is the height and circumference of that valve robust enough, so to speak, to acid down to the stomach? That's the initial evaluation. Next, generally we'll get a barium esophagram, which demonstrates the contractility of the esophagus and how well it takes food down into your stomach. Generally, this will also show any dysmotility issues of the esophagus and things that we might need to think about while during the evaluation. Next would be we do routinely esophageal manometry, which then specifically tests the contractility of the esophagus to make sure we're not dealing with any underlying dysmotility issues that would alter the way we plan surgery.
Right. Fantastic. I do see quite a few questions popping up on Facebook, so I'm going to pass it over to Karen to get through some of those questions. Karen, take it away.
Thank you, Andrea, and welcome, Dr. Marble. Thanks for being here tonight. We've got a few questions. We've got Christian is asking, is there a reason why PPIs don't help much, as much as they have in the past? I think he's been on PPIs and they're not really working anymore. Is there a reason for that, or?
Yeah, so sometimes what I say is everybody's different. So one PPI will work for someone and it might not work for someone else. Also, I feel I've seen that PPIs lose their efficacy the longer they're used and the same type. So if there is someone who doesn't want to undergo surgery, but still wants to control their reflux, I switch their medication over to something else. So I go from omeprazole to pantoprazole. There's also newer agents too that are always developed that can also control that reflux disease. And so you just really got to find the right thing to work. Now, using a combination of a PPI, such as omeprazole, with an H2 blocker is usually pretty effective at treating reflux disease. So that's a possibility and something he should talk to his primary care physician about doing.
Thank you. Could you expand on the H2 blocker? There might be some people watching tonight that are not familiar with H2 blockers and what exactly they are.
Yeah, so H2 blockers block, it's called the receptor H2, and that is also, it's a different mechanism than blocking than a proton pump inhibitor. So it blocks the, so to speak, the triggers or the neuro signal that allows for acid to be produced by some of the cells in the stomach. And so it's a different mechanism altogether, but it still has the same efficacy.
Oh, thank you so much for explaining that. We have a question also from Philip, and he asked, how soon are you able to see new patients for reflux, and what are the steps needed to get a TIF? I think we kind of touched on some diagnostic testing, but I think he's just wanting to expand on that a bit.
Yes, so the generally we see people referred to us from their primary care physician. So if once that's in place and we have the referral, we can usually see people within anywhere from 1 to 3 weeks, depending on how busy we are and everything. But generally, we get people within 3 weeks. And if it is more urgent, then we, Dr. Carter and myself, usually will get them in sooner. Then from that point, we do all the evaluation. Sometimes it takes just a few weeks, and sometimes it can take a few months, depending on the patient and how things are moving along. We also need to perform, make sure that they're medically able to undergo some sort of procedure like that, so their heart's okay, lungs are okay, and everything. And then the TIF, do we want to talk about that right now?
Sure, that was perfect timing. What is the TIF procedure, Dr. Marble?
So the TIF procedure is short for transoral incisionless fundoplication. Decades ago, there was developed an anti-reflux surgery that is kind of the mainstay therapy, still across the nation. However, due to its side effects of gas bloat, dysphagia, and recurrence, it's called a hiatal hernia repair with a Nissen fundoplication. Nissen, that means we take part of the stomach, top part of the stomach, and we wrap it around the esophagus and create sort of a like a hot dog in a bun effect, and that kind of helps put pressure on the esophagus to keep acid down. The problem with that is then people, the worst symptom of that's gas bloat, where they're not able to, they swallow air, but they're not able to regurgitate it back out or burp it out. They can no longer throw up, and so gas builds up, and it's very uncomfortable for the patient. I've seen several people with this symptom, and the transoral incisional fundoplication, it's still doing a fundoplication, meaning we're still creating a valve, so to speak, or a fundoplication, a built-up area where the acid can now still be blocked without creating the effects of gas bloat and unable to throw up. So I have not had a patient yet that cannot burp. Usually they can burp. Some say they can't throw up really, but most of them say they can still burp. They don't get the gas bloat, as well as they say the acid's gone. They're no longer on medications. And so it recreates that fundoplication. I don't know if there's any visuals we have that can help show. It's kind of hard to
explain it without. We just don't have it queued up today, but we can definitely post it on the animation. So Karen, maybe you can pop up the animation, or Christian, our producer that's watching today, can pop that up on the side over here. But yeah, can you explain what is the reason why the Nissen versus, there are side effects with the Nissen versus the TIF procedure? Because you were mentioning, you're doing similar things, but you have less side effects, obviously, with the TIF procedure. And I guess the question we always get is why? Or why do you think that happens?
So the main reason why I think that happens is because it's not as aggressive of a fundoplication. So we're not taking the whole stomach and securing it around the esophagus. That makes for in a way, a tighter fundoplication, or tighter wrap around it. It also can cause symptoms of gastroparesis, or anytime we mess with the stomach, we can alter the way it contracts and pushes food down. And so with manipulating the stomach a lot like that, it can also lead to those same side effects. The TIF doesn't do that as much. The TIF isn't taking the whole stomach and wrapping around there. It is basically leaving the stomach kind of where it is, and using little fasteners, so little plastic fasteners that we do about 270 degrees. If you imagine, the tube coming down in about 270 degrees, about 3/4 of it, we're taking it, we're building up tissue all around it, but we're using where the stomach is located in its native form, so to speak. So we're not manipulating as much.
Fantastic. Yeah. Thank you. Christian, our producer, just popped up the animation. So if you're curious, you can press play and watch the animation that Dr. Marble just explained. Now, can you talk a little bit about the before and or pre kind of prep and then post-op, what to expect kind of after you have the TIF procedure? But I just thought of something. Before you do that, we didn't really get into much about the hiatal hernia, and maybe you can explain how that contributes to and what you have to do if you do have to repair that.
Yes. So during endoscopy, as well as manometry and the barium swallow, we can always identify hiatal hernia. Sometimes there's 4 different forms of hiatal hernias, and I'm not going to go into that. Generally, they don't always have to be repaired, but there's certain types that do need to be repaired, not just because of reflux alone. Performing a hiatal hernia repair so a hiatal hernia is a defect within the hiatus, or let's say the diaphragm. And as your esophagus comes down through the diaphragm, there are 2 muscles, the crura, that surround each side. Now, usually those are kind of tight next to each other, and the esophagus goes down between them nicely. The hiatal hernia is a enlarged hole or enlargement of that area where the esophagus goes through. And that creates a problem, because now the stomach can actually slide up into your chest, effectively decreasing the additional effect that the crura or the diaphragm has to help keep reflux down. So a lot of people with hiatal hernias have reflux, a lot. Now, to fix that hiatal hernia, we do that laparoscopically, typically through 5 incisions, all up in the upper part of the abdomen. We take the stomach and the esophagus, pull it down, dissect circumferentially around that, take the hernia sac out, and then make sure that the stomach sits relaxed and freely inside the abdomen without any tension, because tension would effectively pull that back up. We do use absorbable mesh, so it's a mesh that stays about 2 or 3 months and it dissolves on its own. It's not one of the permanent ones that have a lot of the negative effects of erosion into the esophagus or other organs. So, but including in the hiatal hernia repair, we do close the defect with suture and bring it closer together, and that is usually done depending on how large it is. That it'll change depending on how many sutures we use and everything in the mesh. So,
thank you. I appreciate that. And do you want to let the audience know? So when you repair the hiatal hernia, do you also do the TIF procedure concomitantly or combined, if you will?
So yes, we do. So after completing the hiatal hernia repair, we close everything up, and then the TIF procedure is done through an endoscope. And we first put the endoscope down into your stomach. We take a look. We make sure that there is no evidence of herniation, reherniation, or whatever through the hiatus that we just repaired. Hopefully not. Otherwise, we're not doing a good job. We also measure how long the esophagus is to help for our TIF planning. From there, we will take that out. We will marry it, we call it, or put the endoscope into the TIF device, and then put that back down into your stomach and perform the TIF procedure itself.
In one procedure.
Yeah.
Perfect.
So that, yeah.
Thank you. Can you talk about what they can expect kind of day of and then after? A lot of people hear about, the diet and how can they eat afterwards, and for how long, and then also, getting back to normal life. What does that look like for someone or any of your patients that you've had this procedure done?
Yeah, so generally, they love it. Of course, the diet. They, they so excited about the weight loss that they're going to have. No, I'm just kidding. So the on the day of surgery, we don't have you eat or drink anything. That's when something you expect. Depending on your health and overall um, comorbidities that you have, we make some other medical tests the day of or a couple days before the surgery to make sure everything looks okay. After the surgery, once it's done, you get admitted to the hospital. We will perform a post-TIF or post-hiatal hernia TIF esophagram. And so what we're looking for that, we want to make sure that the contrast passes smoothly. There's no leak of the esophagus. And I don't think this is routinely done, but this is something that Dr. Carter and I feel pretty strongly about. We want to make sure that everything looks good before we proceed with the diet. After that, there is a special diet, 6 to 8 weeks long, of mainly liquids and then soft foods eventually. So usually, I think it's the first 3, even 4 weeks, you're on mainly a liquid diet. And in the first week or two, those are cold liquids. So, and from then, you advance into more softer, like cottage cheese. You can then get into some mashed potatoes. And about week 6, then we can usually get you onto your like a GI soft diet and be okay. Often what I'll tell patients after the procedure is that your swallowing may be affected. Actually will be affected, but it may be affected for long term. If you think about it, we've just taken where this thing was wide open, your valve was wide open, and just kind of going in, where all of a sudden we've kind of tightened up a bit, and that tightening up can change the way food goes down into your esophagus, and so it's going to feel different than what you've ever experienced before, and you have to get used to maybe having smaller when you swallow, smaller bites, stuff like that. Things that we should actually be doing, but we don't in our and generally tell people they will expect to lose up to about 10 to 15% of their weight during this period of time. So,
yeah, I heard one physician say, make sure every bite gets to touch every piece of your tooth when you're chewing to eat. I was like, huh, that's interesting. I guess he was trying to say to chew your food all the way and then eat slowly. So yeah, just changing the way that you eat, which we all should probably do. I did see a couple more questions pop up, so I'm going to pass it again over to you, Karen.
Great. We do have a few questions. One question, do all surgeons use mesh to fix a hiatal hernia, or can you fix it without using mesh?
So great question, because mesh does get a bad rap. Now in this area, yes, I would agree, mesh is not good. Now, I do use mesh, but it absorbs in about 2 to 3 months. So there's absorbable mesh, biological mesh, we call it, or non-absorbable, and that's permanent. That's made out of some sort of plastic sheet, so to speak. There's different materials, tons of different materials out there. It's important in this area to use an absorbable mesh. Or no mesh. In training too, there were probably 1 or 2 surgeons that didn't. The majority of the other ones did. They all used some sort of absorbable mesh. I feel very strongly that no permanent mesh should go in this area, because if you think about it, the esophagus is an organ that is moving all the time. Your stomach is kind of moving. It's a muscle, and the muscle is exposed to the outside, constant movement. So any type of permanent, meaning something that's going to last longer than 3 or 4 months in there, might rub on there and eventually erode into the esophagus and cause pretty major problems. So I think only an absorbable mesh or no mesh. The reason we use an absorbable mesh is that it gives it extra time for reinforcement of the hernia repair. If you imagine this is muscle we're sewing together, it's not like it's not a tough fascia, so to speak, of the abdominal wall. This is muscle fibers, and they can tear. And especially in this area, that's why there's a higher recurrence rate of fixing a hiatal hernia than most of the other hernias that we fix in the body. It's just because it's just the muscle. It's not the best tissue that we can use, but it's the best we got, of course. So.
Perfect. Thank you for that. And that kind of goes into our next question. How soon after the TIF procedure can I resume exercising?
Oh, excellent question. Did your exercising? That's great. 6 weeks. So no heavy lifting over 15 to 20 pounds for 6 weeks. You can walk. You can start vigorously walking. You can be active to a point, but nothing that will put stress or strain intra-abdominally or on the abdominal wall muscles. And that is what happens is anytime you lift something heavy, your muscles contract, and that increases the pressure inside your belly. And if you can imagine that all your belly stuff is going to kind of push out, including your stomach is going to push on that hiatal hernia repair or the TIF. And that might tear it. And so in order to get the best results, we have found that waiting 6 weeks before any type of vigorous exercise is best.
Excellent. And I have another question. If I don't treat my acid reflux effectively, what can happen long term?
Oh, good question. Because this is, I've seen a handful of people now in the last couple years that have developed cancer, so esophageal cancer. Now, esophageal cancer is not that common in our society, but it used to be that alcohol and smoking were some of the leading causes of esophageal cancer. Well, now it's actually turned out, now it's more common we think that acid reflux has been more common cause of it. Is it still common? No, it's not very common. So that's probably the worst outcome that can come from having untreated acid reflux. Generally what will happen is when the acid is constantly exposed to the lower part of the esophagus where the connection between the stomach and the esophagus is, it will start to make changes of the cells, and those changes are called metaplasia. Another name for that is also develops into something called Barrett's esophagus. Okay, now Barrett's is kind of the first first identification that there's chronic reflux or acid exposure to that area. After that, Barrett's, it starts to develop into low-grade dysplasia, then high-grade dysplasia, and then cancer. Not everyone, transitions all the way to cancer, like I said. Not everybody even goes to dysplasia, but it can happen. And so once we start to see Barrett's, then we have to do routine biopsies every 6 months to a year to make sure we're not getting those dysplastic changes. And those are brought about because of the acid. So it's wholesome.
That kind of leads to my last question. If I have Barrett's esophagus, can I get the TIF procedure?
Yes, you can. You will still need the surveillance EGD. However, this can also prevent the acid reflux. And by preventing the acid exposure, that will decrease the chance that likely that Barrett's is going to progress from Barrett's to dysplasia. So yes, you can.
Perfect. That's all I have. Back to you, Andrea.
Thank you very much, Karen. Well, Dr. Marble, thank you again for joining us tonight for our TIF talk. But before we conclude, I always kind of end this way asking our guest speaker, if you had one or words of advice or one thing that you would tell, or if it was your mom or your family member or your child, what would you recommend to them if they were suffering from chronic GERD?
Yeah. I would recommend them to get evaluated, figure out the cause, check it out. There's treatment options out there. You don't have to take a PPI the rest of your life. You can at least know the options. Now, if you choose that, you don't want to go surgery, so to speak, the TIF or whatever, then that's your choice. But at least get evaluated and see what it's going to be like. The nice thing about the TIF is that if there's no hiatal hernia component with it, and it's just reflux, then performing just the TIF alone is not as invasive as an anti-reflux surgery like the Nissen repair that I described earlier. So get evaluated, figure out what's going on, and have more information that can help take care of your health for the future.
I love that. Get evaluated. That's the best thing you can say right there. Well, again, we can't thank you enough for joining us this evening. And for those of you who are in the, where are we? Southeastern Arizona area, Safford. It was Safford area. You can find Dr. Marble or his partner, Dr. Carter. And if you're not, you can go to gerdhelp.com. We do have a website that has a physician locator, and you can put in your state or zip code, and you can find a physician that's you. So again, thank you, Dr. Marble, for being here tonight. Thank you, everybody that joined us this evening, and you can catch us next week, every Tuesday, for our TIF Talks. Until then, have a great evening. Bye.